Okay, let's get started. Our first poster presentation is language-based detection of adherence to evidence-based psychotherapy scripts. I'll let the presenter introduce themselves, and please take it away.
Hey everybody, let me just get this set up. Okay, everything look good? Great. Um, hey everybody, my name is Samuel Campione. Glad to be here today. I am a predoctoral researcher at Stanford University. Let's just jump right into it. So, access to gold standard treatments for mental health disorders or evidence-based psychotherapies, EBPs, is limited by the number of trained providers. There are digital training systems that are emerging to help scale clinician training. And part of this brings new opportunities for um, automated monitoring of therapist fidelity and performance. One example would be written exposure therapy, a treatment for PTSD. A core piece of written exposure involves clinicians reading scripts or passages word for word at specific moments of the treatment. Um, so this raises the question, can we detect therapist adherence to these scripts? Um, to answer this question, we looked at a data set of therapist script usages and compared simple text similarity methods versus LLMs at this script detection task. Overall, we found that the simpler text methods performed better than LLMs. Specifically, in our error analysis, we found that the LLMs struggled with paraphrase scripts, which is actually a really costly error because adherence to written exposure requires verbatim script usage. The text similarity methods never struggled with this. Um, Overall, these results provide some evidence that simple NLP methods can help provide an approach that is effective and privacy preserving to help with the implementation of these evidence-based psychotherapies and supervision and training. That's all I have for you today. Thank you.
Thank you, Samuel. Let's see if anyone have any questions. And then if you do, please just cut off mute, and then let's start from there.
I have a quick question. Oh, sorry.
No, go ahead.
Yeah,
I'll go next.
Okay, Samuel, thanks. This is really great work. I have a quick question. You mentioned it being privacy preserving. Can you elaborate more on that? Thank you.
yeah. So there I specifically mean that many of the large language models go to external AI providers like Anthropic, OpenAI, and these simpler models you can implement on your own computer. So in that way, no HIPAA protected data goes to external servers.
Thank
And
you.
then Amelia.
Hi, this is super interesting work. Thank you for sharing, Samuel. And if you're an intern, congrats on almost being done. I know the simple text results made sense with written exposure therapy structure. I'm very interested if your team is considering expanding this work to therapies that aren't as scripted as written exposure.
Yeah, that's a great question. Written exposure is a little unusual with these script passages that need to be read. Um, I think that we have used this, I've been using this as evidence that these more simple NLP methods can help complement the um, the LLMs in this space, and maybe that there are certain tasks that are better suited for that there are algorithms that are better suited rather than just throwing everything towards an LLM.
Thank you.
Thank you very much, Samuel. In the interest of time, there are a lot of good questions, but for the interest of time, we'll move to the next poster presentation, and then we can come back if we have more time for more questions. So our next presentation would be expert lab prompt refinement for an AI-based therapist training tool. And please take it over.
Thank you. Okay, can everyone see this okay? Yes, cool. Nice to meet you all. My name is Shreya Singhvi. I'm also a pre-doctoral researcher at Stanford. Thank you, Sam, for perfectly queuing up my topic. We're in the same lab. So as Sam mentioned, written exposure therapy is an evidence-based treatment for PTSD. It's quite short. It's only 5 sessions, and it's very effective. So that means it's easier to scale than longer treatments. However, there's quite a bottleneck when it comes to therapist training. So, to help close that gap, our lab is building a therapist training tool where clinicians can speak to an AI simulated patient and then they get real time feedback from an AI consultant that's been modeled to emulate expert clinical guidance. So when building this AI consultant, we realized that there aren't established best practices for getting a language model to follow a specific clinical protocol. And that's an open problem that we were hoping to address. So to build the initial consultant model, we fed it the wet training manual and also some supplementary training materials. And then we had 2 expert clinicians review the model's feedback on 10 therapist-patient exchanges. So for each exchange, they looked at the strengths and weaknesses of the model's response and feedback, and then documented their own clinical reasoning and wrote revised ideal responses to the therapist's behavior. We took these revised responses and used them as few-shot learning examples for the model to continue to iterate it and improve it. And what we found was that in order to build a clinical LLM like the consultant we have here in the middle of the poster, giving it just the training manuals and the supplementary materials is not enough to make it supervised like an expert. So, for example, the training manuals don't really talk about how short dialogue between scripts is allowed. So this was flagged as a deviation, even though it is okay to do in treatment. And then also, the consultant was flagging very small errors like a typo in the script, but missing bigger errors like skipping an entire script section or truncating the post-writing check-in. And then finally, we found that encoding those smaller, subtle supervisory skills, such as leading with strengths or explaining the reasoning behind a correction, got better with few-shot learning, but they were still the hardest to encode. So this work just makes it clear that involving experts in developing modality-specific clinical LLMs meaningfully improves the feedback, and this also offers a refinement workflow that others could use to align their LLMs with specific evidence-based protocols. Thank you.
Thank you very much, Shreya. Let's take a few questions.
I have a question. Again, really interesting work. So you mentioned the document that you inputted in the current system was not enough. What other sort of clinical knowledge sources have you thought of integrating into the system? Like, are you going to test on that soon and compare to this?
Yeah, so we have a lot of different documents. There are transcripts of example sessions that we've inputted with feedback. And then also we have a really long question and answer document of really common questions that therapists might have about the treatment that these experts have written detailed responses on. So we fed that to the model. And then we're continuing to iterate. So every time we see, for example, feedback that doesn't look great, we will feed it into the model and say, this is our revised response. And so by doing that few-shot learning, it's continuing to improve as we go. And we're using just the data that people that we're testing in the training platform and using all of the transcripts from that.
Okay, thank you.
Thank you very much, Shreya.
Thank you.
Our next poster, unfortunately, the author isn't live with us today, and then she shared a copy of the pre-recorded version of it, and then I'll screen share it right now. And please let me know if the audio is okay. Here, one moment.
Hi, and thank you so much again for listening. My name is Jean Garcia Davis. I am a public health nurse. I'm also a caregiver, and I'm delighted to be with you to share this practical checklist tool that I had developed that's trauma informed and intended for general public users, particularly families, parents, educators, and children and youth, for navigating mental health AI integrated applications. So this work entailed, you'll see the methods noted here. I invite you to take a look at it further. I won't read through a lot of the context. Much of that is also not new to many of you who work in research, but also on the practitioner side. And then in terms of the explosive and fast pace of products that have been developed around mental health AI applications, which I'm calling applications that aren't necessarily considered medical devices and products under regulatory review. So this effort proposes a mini user safety checklist that's intended specifically for general public users, patients, caregivers, but also health workers, as so many of the tools for assessing and evaluating safety have been targeted towards psychologists, psychiatrists, mental health care licensed healthcare professionals. So this is meant to really help the general public, where there is a bit of a delay and lag, given the lag also that we're seeing in related policy. And so it's meant to assess first-time use and also be an ongoing tool for regularly assessing safety, looking at 5 domains. So the 5 domains and 10 questions here would be scored at baseline by a user and then every 3 months. And so it's meant to just be a handy tool, but also for communication around these applications. It's meant to empower users with the digital mental health technology literacy. It offers a practical guide, a scoring checklist, and it's meant to foster this shared accountability for safety standards, not only in promoting awareness, but also having the literacy, the application of it in terms of the language, and also having tools that can be used to have a more consistent and clear conversation, not just in policy and practice, but also wherever people are living, working, playing, and engaging with these tools on the front lines. And so the tool is here in the middle, and then there's also, I included in the standards, the 6 principles for the trauma-informed approach. I invite you again to look further at that. I use that lens. And then with the application too, there were a number of tools that have been developed over the last 10 years. And so those are incorporated here. There was a number of different crosswalks that I did with the existing American Psychiatric Association app evaluation tool, numerous commentaries on that tool, and then also just taking into account the recent American Psychological Association health advisory, some of the guidance that was listed for specifically not just healthcare workers, but also general public and users and families. And so here on the left, you'll see the chart where a table of where I started to do the pilot. Again, there were limited time and resources at the time of writing, so I plan to continue it and evaluate. I did the top rated mental health AI integrated apps, and you'll see here the total users and then the scoring. So there is a score sheet, and I looked at the different scores across each of these, and I'll plan to do it again in a few months, so that it's more of a dynamic instead of a static tool. So I'd love to discuss this with you further. If you're interested, feel free to reach out to connect with me or collaborate, and seeing what the next steps look like. They're very exciting. I think there is such a possibility for us to really apply, do no harm and ethical principles, not only to humans, but also understanding that artificial intelligence will also, to err is human and also artificial. And then really understanding what are access issues to digital literacy tools and to existing mental health care for people who are not at the table and who are not being engaged, or whose data is not being sourced with a lot of the development and training of these tools. So thank you so much, and look forward to connecting with you.
Okay. So if you have any questions for our author, feel free to shoot in an email or reach out to them via the conference portal. So our next presenter would be voice-based conversational AI for personalized multi-domain lifestyle interventions in older adults, a feasibility study. Please take it over.
Right, let me just do some setup here. Can folks see the slide? Yeah, okay. All right, hi everyone, I'm Talia, a fourth-year PhD student in information science at Cornell Tech. Today I'll be presenting with William Huang, a second-year master's student in information science at Cornell Tech. So mild cognitive impairments, or MCI, affects about 10 to 15% of older adults above 65, and it increases the risk of progression to dementia. So while there are no current treatments for MCI or one that can reverse cognitive decline, studies have shown that multi-domain lifestyle interventions can help slow down cognitive decline. The challenge is that these interventions can be difficult to deliver and sustain at scale. Accessing digital approaches such as mobile apps, web-based platforms, and telehealth interventions often struggle with long-term engagement and adherence. So to address this gap, we designed and developed ARC, which is a voice-based AI care assistant that delivers evidence-based lifestyle interventions through natural conversations. So ARC supports cognitive, mental, physical, and social well-being using strategy adaptation memory training, behavioral activation, motivational interviewing, and also reminiscence therapy. So as our first step here, before we deploy this system into the MCI populations, we conducted a 3-day study at home with 81 older adults and collected around 486 conversational sessions. Now I'll hand it over to William to share our findings.
All right. So as for the results, on average, older adults engage in 19.6 turns and about 6 minutes per session with ARC, and found it useful, easy to use, and worth using again, with similar engagement across all 6 session types. On a 5-point scale, usefulness, ease of use, and intention to use all stayed positive, around 3.2 to 3.9, consistently across all 3 days. Participants also felt ARC's interactions were personalized to their health status, preferences, and abilities, each rated around 3.8 to 3.9 on the same scale. This tells us that voice-based conversational AI can feasibly deliver personalized wellness support to older adults at home with strong acceptance. Our next step is a longitudinal deployment with older adults with MCI, looking at sustained use and integration into caregiving ecosystems. Thank you so much.
Thank you very much, both. Let's take some questions. If there are no questions, I'll ask one. What do you think will be the next step for the study?
Yeah, that is a great question. So our next step, which is actually already approved and gonna run soon, we're integrating other source of data instead of just like natural language data. We're integrating wearable sensor data to help inform and personalize our physical wellness sessions, and also for safety monitoring. And we're studying it instead of in population that are not confirmed to have MCI, actually with folks who are confirmed to have MCI.
Gotcha. Nice. Thank you so much for your time.
Thank you.
Thank you.
Let's move to the next poster, which is building safety in evaluating crisis response in AI career coaching tools.
Can
Please
I
take
ask
it
a
over.
question real fast on the
Oh,
last one?
yes.
Apologies. I'm sorry. I was a little late. I was trying to find my hand. So you guys are using which model for this? Which LLM?
So these was a GPT-4o, but we have two different models deployed. There is a speech-to-speech one, Whisper, and that version is already retired. So we're using the new versions of Real-Time API, but through Azure.
Okay.
It's
So
OpenStack
what are you
platform.
guys I guess if you're measuring cognitive decline, like how are you combating that essentially with, if I understand you correctly, how are you combating that with like the hallucination or even the other side of it where the model isn't remembering what content's already been provided?
So the cognitive decline in the older adults, right? And your
Yeah.
question is about the model. So right now, this was like a short 3 day study. Our next
Mhm.
study is about a month. That's the only one that we were approved by our IRB to do, no longer than that. I think right now, we have a pipeline where baseline cognitive status is being the context of different sessions and also previous check-ins. I was showing that we have check-ins that would be done weekly. So this is the data that we use for the model to understand where people are and then contextualize their interventions per session based on that. The first baseline status is done by questionnaire, but then this data then wrapped into what we call baseline profile. So their scores is interpreted in natural language. So there's MoCA score, right? And it's just going to be like a summary of someone's MoCA, which is their cognitive decline profile, and then that would be the one that we track at different time points.
Okay. All right. So
Yeah.
thank you. One, thank you. Yeah, this is a lot of content to consume. I know it's all in one slide.
Yeah.
I'm trying to listen and, review. So thank you. Appreciate it.
Thank you.
Thank you very much for the question. So our next poster is building safety in evaluating crisis response in AI career coaching tools. Samuel, please take it over.
Can you guys see that? Okay. So I am Dr. Sam Faulkner. I am a licensed clinical psychologist, and in my day job, I help run psychological services and work in crisis settings, emergency department, hospital settings. But I also do consulting work for multiple things, including AI. My co-author here, Dr. Huang, is also a licensed psychologist, and she has a private practice where she does a lot of work with twice and thrice exceptional children, but also obviously does some consulting work. So we were brought on as consultants for an AI career coaching tool, and we were brought on initially because there was this awareness that increasing awareness, of course, that people are really disclosing very personal, intimate things when they're talking with chatbots, in particular when they're in vulnerable situations. And so we were brought in to try to support that effort if it shows up in this chatbot forums. So obviously, job loss is actually a predictor of suicide. It's a really, really powerful, highly correlated, causal predictor of death by suicide. And so it's something that we wanted to take very seriously, knowing that, imagining someone might have just lost their job and be talking with a chatbot to get support for finding a new job, but also may, in the context of that, receive emotional support and then disclose things about their suicidality or self-harm. We know that in general, large language models don't do very well when it comes to responding effectively to suicidality. They really don't pass the many of the evaluations that we've seen. And when you compare them to clinical expertise, often they fall short. And so we wanted to design something to combat that. So we developed a protocol, did a deep dive in the literature on not just the crisis response literature, but also how you build ethical, safe AI tools and digital mental health tools. And we developed a protocol where we tested this chatbot in an initial phase, an initial round, and it really failed all the time. And so the testing protocol looked like there's sort of hard pass, hard fail rules, but there's also, we would rate the chatbot's responses as expert clinicians on sort of a Likert scale rating across these safety domains. And it really passed across the board the first round, but we were able to do this iterative feedback process with the software engineers and improve the protocol and the way it responded, and found that actually with that feedback, we could significantly improve its ability to not just detect risk, but also respond in an evidence-based way to some of the crisis stuff. And so that's really what we did. And I think that the big key message here is that risk detection itself in chatbots is not sufficient. We really have to build in human experts into the design of how they respond effectively, as well as create spaces to provide resources and a human in the loop when suicidality or crisis shows up.
Thank you very much for the presentation. Let's see if anyone have a question or two. I'm seeing a question asking, are there job loss specific resources or conversations that are helpful for these users?
I'm sorry, what was that again? Are there job loss specific resources that are helpful for these? So I think in this platform itself, there are tons and tons of resources for people who have lost their jobs. What we were trying to build on the safety side at least, is the ability to have sort of a triage process for manual review from humans, which is also followed up by potentially contacting with a crisis resource specifically when that stuff is disclosed. But in general, yeah, there's a ton of stuff in the context of the app itself that is useful for people who are navigating job loss.
Thank you very much. So our next poster presentation is AI-driven language monitoring and peer support in a digital mental health platform. Please take it over. Um, is Dimitri here? Okay. So let's see. It looks like the presenter for this one is not here with us yet, and then we'll move on and come back to see if they will join later. So the next poster is leveraging AI for delivering culturally competent mental health care for immigrants. From yeah, okay, cool. Okay, go ahead, take it over.
Hi, thank you so much. My name is Zhouran, and I'm a PhD candidate in public health at University of Massachusetts Amherst. This has been just a project that I've been working with over the past year with Dr. Van Cook, who is at University of Illinois. Uh, the title of our presentation is Leveraging AI for Delivering Culturally Competent Mental Health Care for Immigrants from Marginalized Identities in the US. So I was interested in this project as it is oriented towards immigrants who are from marginalized identities, and I'm a student from India studying public health, and I was very curious about how we could leverage AI for delivering mental health care in the university settings for students. So as we've seen in this conference is there's many papers on mental health treatments through use of chatbots, different papers related to policies, perceptions, and ethical challenges of AI, uh, which is all really crucial. But also, I was really interested in the role of generative AI in providing cultural competent care for immigrants from marginalized communities. So my main research question was the culture, how to assess the cultural appropriateness of generative AI produced clinical outputs in developing a cognitive behavioral therapy informed treatment plan for a college student of Indian descent experiencing major depressive disorder in a university setting. So we employed a discourse analysis of generative AI to critically evaluate the degree to which AI produced CBT treatment plan reflected the cultural responsive practice for a student. So what we did was we created a case study of like a student who is experiencing depressive symptoms and is in a university. We added different layers of race, class, gender, and then we put that up in Claude and we asked Claude to like generate a CBT treatment plan and saw what it made. And then once we got that output, we put that again in Claude and asked it to employ cultural psychology and Indian psychology frameworks to the treatment plan. And then what we found was this the main output was this table, table one, which is the session by session treatment plan with incorporation of Indian psychology frameworks. So you can see here there are many things from the Bhagavad Gita, many terms from yoga, from other like religious and Hindu frameworks. So that is what AI generated. So what we found was that all this production, the report was very clinically sophisticated for the Indian diaspora, but there was a big conflation of Indian identity with Hindu psychological frameworks. And not holistically just looking at the intersectional identities of people who are from Indian backgrounds. And there was no like uh, delineation based on religion, class, gender. It was all conflated together, which felt very oversimplified. But on the surface, it looked very sophisticated as like a clinical report. So the main implications of this paper are instead of like a surface level adaptation of culturally competent care, moving towards content development that reflects the full complexity of immigrant and diaspora identities.
Thank you very much for the presentation. We have time for taking one question.
I have a quick question.
Hi.
Can you hear me?
Yeah.
Yeah, thanks for your presentation. I'm also like echoing with your thought about AI when you actually ask about the culture. It's kind of simplify and flatten the culture because the like majority of content trained in AI is actually generated in the Western context. So I'm just wondering, what do you think about the like potential or limitation? I see actually more limitation these days, like even though I also thought like the potential at the beginning.
Yeah, I do feel like there's so much potential, again, like because of like lack of availability of care, especially in even low and middle income countries, people will be turning to AI chatbots regardless. So I definitely see that use of like this kind of work so that we can actually make this better for like the community that will be using it. There's like many studies on how people from marginalized identities and in low and middle income countries are already using chatbots very frequently. So I do feel like a lot of potential in either medical education or just in consuming, um, getting medical information through AI. But yeah, I think definitely like just this oversimplification can be made better.
Thanks for your answer. It's like very problematic. Like, sorry, we can follow up. Yeah.
Yeah, thank you very much for the question, and thank you for the presentation. So our next poster presentation is designing AI enhanced digital mental health interventions, user perspectives.
Great. Let me just share my screen. All right. Hi, I'm Rachel Cornfield. I'm an assistant professor at Northwestern University, presenting some qualitative work to really understand how potential end users of generative AI tools perceive them, and in particular, how they perceive general purpose AI tools like ChatGPT, et cetera, versus some of these emerging purpose-built tools for mental health support. Many people are, of course, using general purpose conversational AI tools, but fewer are using purpose-built tools. So we really don't understand how users perceive the benefits and potential harms of these approaches toward using AI for mental health. So in this study, we recruited 28 participants who all self-reported experiences of depression, and they engaged over about a month in an online discussion group where they shared their experiences with digital mental health tools, as well as with generative AI. They commented on uses of generative AI for mental health, as well as responding to 4 hypothetical purpose-built tools. They were a therapy chatbot, an SMS-based system that combined rules-based and generative content, a conversation rehearsal tool that was user-directed, so the user can set up a simulation and practice a conversation, and then finally a coach support tool wherein the AI is used to help a mental health coach deliver support more efficiently and potentially effectively. So we were obviously not capturing all possible uses of AI. There are many uses that are being investigated, but we wanted to put on the table a broad sample of potential uses so that we could give participants something concrete to respond to and talk about how different features might be related to potential benefits and risks of these tools. So what we found is that most people had used general purpose AI tools, but not purpose-built ones. And in fact, they had rarely used general purpose AI tools explicitly for mental health. Sometimes they said, oh, for companionship, but not for supporting my mental health. So the way that you frame that question seems quite important because they're making a distinction there. Participants also felt quite ambivalent about using general purpose tools for mental health. They liked the personalized support, convenience, and non-judgment, but they raised serious risks like over-reliance and displacement of human relationships and expertise. When we showed them these purpose-built tools, many expressed enthusiasm, learning about these opportunities to use tools that were specifically to address mental health concerns. And they specifically wanted tools that address the risks that they described with general purpose tools. So to the extent that purpose-built tools support human connection, integrate human expertise, allow user control, and help users build specific valued skills. So overall, we found strong enthusiasm for purpose-built tools, a lot of concerns, although some enthusiasm for general purpose tools. And in general, they responded positively to several of these hypothetical tools, suggesting opportunities to embed large language models within a variety of expert-designed intervention systems. So happy to take any questions, and you can feel free also to contact me. My email is on the screen there. Thank you.
Thank you very much, Dr. Confield. Yeah, please.
Sharon, go ahead.
Oh, thanks. Rachel, this is great. I feel like the field right now is talking a lot about are folks even going to use these purpose-built tools that now people are pouring a lot of money into? So I'm really curious from your perspective, do you think the enthusiasm is actually going to translate into use, or what's your
Great
take?
question. I mean, I think it's an uphill battle because these tools are already out there. People are already using them, these general purpose tools. On the other hand, our data here, I mean, it's a small sample, it's a qualitative study, but they suggest that there's a group of people who have mental health concerns, but they're holding back from talking to ChatGPT or Gemini or whatever about managing their mental health. So maybe it's not an all or nothing thing, but there could be a potential subgroup of users who are holding out for something that's evidence-based and really designed to meet their needs. So I think it's an uphill battle to reach everybody, but I think there are people who are reachable and waiting for these tools.
All right. So my question, you had 4 different options out there, right? So did you see a trend in which one was used more as far as the messaging, the scripting, or the coaching?
Yeah, great question. So these were all hypothetical tools. We shared a vignette of how a user might engage with this tool and how it could help them. There were differences in the levels of enthusiasm that we found, and we found a lot of interest actually for the conversation rehearsal tool. So people who wanted to rehearse mental health help-seeking conversations in a safe environment, set up a simulation for a specific person. Maybe I want to tell my mom about my depression. I've been holding back for whatever reason, but I can set up this safe rehearsal. A lot of interest in that, as well as our hybrid rules-based and generative texting system. People really liked some of the simple things that work for non-AI texting systems, like the predictability. They'll get a message, it's supportive. So we can kind of keep the things that work, but add in generative AI so it can be a little bit more personalized and show understanding when people send back free text messages. But at the same time, I think the other alternatives were also appealing to certain users. So I think the devil's in the details there.
Sweet. Thank you.
Thank you very much for the presentation and all the great questions. Let's move to the next presentation, which is designing digital mental health platforms, user engaging in assessing AI for psychological services.
Hello, just sharing my screen. Can you see it? Hi. Am I audible? Can you see it?
Yes, we can see it.
Good.
Oh, now we can't. Oh, now it's good.
Perfect.
Cool.
All right. So as we all can see that in India, what there is 0.75% of psychiatrists and mental health available per 1 lakh people, which is quite less, and there is a lack of accessibility in reaching out whenever you need someone. So the question was just to understand who understands you the best, your friends, family, a mental health professional, or AI. People said that it was their friends and family, but when it came to actions, when their intentions and their ideas and their trust came into action, they were reaching out to ChatGPT or AI and different Gemini and other generic AI versus specific AI for mental health as well. The idea is to understand what is making people use AI and trust it more, and what is the entire process, the different time points, what are the questions, when do we go to AI to use it for our mental health, for our personal questions, versus when do we exit, when do we stop using it, if we can use it forever, if we can ask them about every question, what makes us engage with it and what makes us not engage with it. This is to understand so that in the future AI is taking over and people are using it. It is accessible any time of the day that we want. We want to make sure that there are future studies that are being able to see the ethics side of it, whether it's safe or not, the harm that it is providing, and how to shape it in a way that it can actually be beneficial to, or at least assess the situation of how risky it is, to understand someone, whom to recommend, what to recommend, and when to stop, when to help them understand how AI is taking shape in navigating their own mental health as well. So what I did was that we did qualitative research, and we built a questionnaire on which we created themes, and further we created sub themes on which using thematic analysis. And what we found was the user expectations, which was that they wanted AI to have some sort of humor or personality. They wanted privacy. It was reliable in the sense that they can reach out to anytime. It is always available, which built the trust. What we understood was that there was what was discouraging the engagement was the idea that there was low confidence in storing the data, that we don't know where the data is going. There is negative environmental impact, and the responses are generic. What users are looking forward to is the idea of personal touch, of the references that, oh, this happened to me in the past and now something similar is happening. For AI to remember you as a person, to use empathy and also use humor and personality, things like using an avatar and just creating a version which is specifically for them. Some people like AI that it is sweet and validating, and some people don't. They want straight, direct solution. They want AI. They want a choice in how AI is talking to them and performing. And the limitations are that the sample data was very less. We need more studies to be done, and AI keeps changing over the years, over the time. So the research needs to happen again and again so that it is valid for the kind of AI, the functionality that AI is able or capable to do. And that is all for now. Any questions?
Any questions for our presenter? If not, I can ask one of them. So in the post, you identify like moments of exit, like when users like drop off in using these tools, um, like which exit do you think seems most like actionable for designers try to improve the retention?
I think the idea of including patience, in the sense of that instead of giving the wrong answers, because most of the time that people get agitated is when their answers were being misinterpreted and wrong answers, or they were just not getting it. So the idea is to understand and ask more questions before answering, because AI is very solution focused and it would just directly give you the answer without even understanding the question. But showing the confusion or just asking more in detail that, oh, I did not understand it, can you elaborate on this part, or what do you mean, can actually help the person also understand themselves better, what they're looking for.
I see. Just so like do more of those like clarification process before jumping right into the answers.
Yeah.
Okay,
Yeah.
cool. Thank you very much for the presentation. So that's all the posters for today. Again, thank you all for coming to the sessions and all the presenters for sharing such a range of work